Good morning, Howard University family. Let me see if I can ask if the panelists would unmute.
Good morning.
Good morning.
Good morning.
Thank you. We're going to go ahead and get started. Good morning, Howard University family. We'd like to welcome you to the panel discussion on social determinants of health. My name is Felecia Banks. I'm an associate professor and chairperson in the Department of Occupational Therapy, and I will serve as your moderator for this session. This panel will focus on the ways poverty and wealth impact health. Panelists will discuss the impact of social determinants of health, including mental health, and suggest policy-driven solutions for healthcare reform. I'd like to begin by introducing our panel members for today. Our first panel member is Dr. LaMarcus Wingate. Dr. LaMarcus Wingate is an associate professor in the College of Pharmacy at Howard University, where he also serves as the director of assessment. Dr. Wingate graduated from the University of Texas Health Sciences Center, where he completed his PharmD and PhD in health outcomes and policy research. He obtained his postdoctorate fellowship in the Stevens Toyek Prevention Effectiveness Fellowship Program at the Center for Disease Control and Prevention, where he received advanced training in economic evaluations of healthcare programs. Our next presenter is Dr. JaNeen Cross. Dr. Cross is an assistant professor at Howard University School of Social Work. She is a former health education and leadership scholar, health policy postdoctoral fellow with the National Association of Social Workers. Dr. Cross has a meritorial appointment with the District of Columbia Maternal Mortality Review Board Committee. Our next panel member is Melissa Weir. Melissa Weir is an undergraduate faculty in the College of Nursing and Allied Health Sciences nursing program at Howard University. She has taught at Hampton University and has served as interim chairperson of the undergraduate nursing program at Howard University. Ms. Weir is a registered and licensed pediatric emergency nurse and a certified nurse educator. We'd like to welcome each and every one of you today who has joined in to dialogue with us. And we're going to start with our first panel member, Dr. Wingate. Dr. Wingate?
I'd like to say good morning to everyone. Thank you for joining us today. So can you all see my screen?
Yes.
Okay. So I am going to be talking about the social determinants of health and its impact on wealth on health. And so here we have a slide which shows the share of wealth which is held by Blacks. And so we're looking at the median household wealth in a typical Black family versus a typical white family. So here we see that the white household has about 10 times more wealth than the typical Black family. And so what's sad is that this has actually persisted and actually in some cases grown worse ever since the civil rights movement of the 1960s. So these are very persistent differences that we see in the obtainment of wealth in between white and Black households. And these differences still remain even whenever we have the same levels of education in between white households and Black households. And so here on this particular slide, what we're looking at is differences in mortality for different subgroups of Americans. And so here they divided Americans into 8 different populations. And at the bottom here, we have what we call Black Middle America, Southern Low Income Rural Blacks, and High Risk Urban Blacks. And what's of note here is the stark differences in terms of life expectancy. So here, the life expectancy for urban Black males was 20 years lower than that seen in Asian females. Of course, that's an unconscionable difference, a very, very large difference here in our country of America, where we have so many different resources. And within males, the life expectancy for urban Black males was 15 years lower than that's seen in Asian males. And the life expectancy for rural Black females was 13 years lower than that's seen within Asian females. And so in this particular article, one conclusion that the authors came to is that one of the primary reasons for these stark differences in terms of life expectancy was income. And so here you can see that the average income for the Blacks is lower than the other populations. And so that leads us to talk about the social determinants of health. So we realize that this may be some people's first time on these particular sessions here. So we would just want to give a brief introduction to the social determinants of health. So they're defined briefly as the conditions in which people are born, grow, live, work, and age that shape health. So really our community plays a large part in terms of our health. And so that's part of what I'm going to be talking about during this particular segment of the presentation. Where we grow up at, where we live, where we work, it really has a huge impact on our health. And so this is different components of the social determinants of health. And so we have social and community context, which I'll be focusing on, but also education could contribute to the social determinants of health and economic stability and the neighborhood and the built environment. So we have different components within the social determinants of health. And what's surprising whenever I present this information to my students is that healthcare is actually not the single biggest factor in terms of impact on health outcomes. So there's a difference in between healthcare and health. So of course, healthcare deals with the different resources which we provide in terms of trying to improve health. And they're specifically devoted to that, such as hospitals, physicians' offices, pharmacies, medications, all those deal with healthcare. But the social determinants of health actually have a bigger impact on health as a whole than healthcare. And so here what we see is that individual behavior is the biggest single component in terms of determining premature mortality. So of course, within behaviors, we have factors such as diet, exercise, sleep quality, staying away from illicit drug use. But these play a much more important role than healthcare in terms of determining health. And so, as Dr. Banks mentioned, I actually did my graduate education at the University of Tennessee Health Science Center in Memphis, Tennessee. And so while I was there, I actually came across an interesting situation, and that being that during my time at Memphis, Memphis was named the hunger capital of the nation, yet at the same time, it was actually the most obesity in the nation. And so this is in a city replete with healthcare resources. They actually have St. Jude's Children's Research Hospital. The pharmacy school, which I graduated from, was actually one of the top 20 in the nation. They have a multitude of different hospitals. The University of Tennessee Health Science Center ensures that they have access to many healthcare resources, but still, they actually dealt with this country where they were actually the hunger capital of the nation and the most obese city in the nation all at the same time. And so just to briefly get to the point here, what's at the root of all of this is poverty. And so lack of wealth. And so there's a term here which we'll introduce called food insecurity. And so this occurs at the household level, but this is whenever people cannot really afford food at some point during the preceding 12 months. And so that's linked to higher levels of obesity. Whenever you think about it, whenever these people are really poor, then whenever they do get food, then they can't make the most nutritious food choices. So they get foods which are very high in calories and high in saturated fats. So there's another term which is called a food desert. And so these food deserts are located mostly in urban neighborhoods and rural towns, and also too predominantly in low income neighborhoods and those with a high concentration of minorities. And so it's in these food deserts where people don't really have a supermarket within driving distance, and they don't have cars. And so it's hard for them to be able to go to a grocery market and be able to attain fresh, nutritious food. So instead, they go to convenience stores, they go to perhaps fast food restaurants, they get foods which are very, very dense in calories, saturated fats, and so they eat unhealthy foods and actually end up being obese as a result of that. And that's in contrast to what we would call food swamps. So food swamps are actually localities where it's not a food desert, where there's a lack of healthy foods available, but instead there's a preponderance, like an overwhelming amount of unhealthy foods available. So of course, this is what we call an obesogenic environment contributing to obesity. And so I'm pretty sure that all of us have seen some type of a scenario like this, where there's just a plethora of fast food restaurants in a locality. And so here, whenever you present these choices to people, then of course they're going to make some type of unhealthy food choices. And this is what we see in our low income neighborhoods, many of which are minority neighborhoods. And so food swamps actually have more of an impact on health than food deserts. Blacks are more likely to live in both food swamps and food deserts, but food swamps actually have a larger impact on obesity and poor dietary choices. So briefly, I want to look at the lack of other facilities in low-income Black neighborhoods, which help to promote health. And so one of those being a pharmacy. Of course, I'm from the College of Pharmacy, so this would be of interest to me, but we find that between 2009 and 2015, pharmacies serving low-income and uninsured individuals in urban settings were significantly more likely to close. And so what's interesting about this is that this is likely to affect their adherence to prescription medications. So if they have some type of chronic disease such as diabetes or hypertension, then they're less likely to be able to control it well because they don't have access to medications at the same levels as other people, because here the pharmacies are closing, so they have to actually end up having to go out of their neighborhood to be able to obtain their prescription medication, so it affects their medication adherence. Also, too, what we know is that whenever we have a greater supply of primary care type providers in a neighborhood or a community, such as primary care physicians, nurse practitioners, then those actually are associated with a lower rate of mortality in a community. But what we find is that minority communities actually have fewer of these types of healthcare providers. And so also what we find is that minority communities, particularly those of low income, have a lower supply of different types of facilities that would help promote health, such as gyms. And those are actually, in some cases, associated with lower mortality as well, too. And so we just looked at how there's a lack of facilities that actually promote health in these low-income Black communities, but unfortunately, there's also an abundant supply of facilities or different types of characteristics which may actually impede on health in low-income Black communities. So this is looking at the Sandtown and Winchester community in which Freddie Gray grew up compared to Baltimore City as a whole. And here we can see that there's higher unemployment in Sandtown and Winchester Park, many more alcohol stores, more tobacco stores, and then also 2 lead paint violations. And so if you know anything about lead paint, it actually predisposes people to violence that actually impairs their cognitive abilities. And so one of my colleagues actually did a study at Morgan State in the aftermath of the Freddie Gray riots, and he actually found that the prevalence of PTSD-like symptoms in the Sandtown and Winchester community after those riots was 22%. And so nationally, we see that the prevalence of post-traumatic stress disorder is about 3 to 5%. So here we see that the post-traumatic stress disorder is on fold about 4 times higher in these particular low-income Black communities. And so with that, I'll end this particular segment, and so that our other presenters can have time to share their views. Thank you.
Thank you, Dr. Wingate. And I guess part of our challenge is how do we begin to tackle the inequities that you shared with us? And so we're going to hear from Dr. Cross at this present time. Dr. Cross?
Thank you so much, Dr. Banks. And thank you for that wonderful presentation, Dr. Wingate. I'm going to expand on a couple of the concepts that Dr. Wingate talked about, particularly related to understanding of how social determinants of health impacts populations. However, the population that I'm going to focus on is maternal and child health. And so, as Dr. Wingate so eloquently discussed, he talked about social determinants impacting how people work, live, how they actually, the outcomes of how they actually engage with certain systems. He talked about pharmacies, he talked about neighborhoods and communities, and how social determinants really impact how people's outcome, how their outcomes can be hurt over a period of time. And I'm going to focus specifically on some statistics related to maternal child health. I'm going to focus first on Black infant health, then maternal health, and then talk a little bit about maternal mental health. Prematurity and low birth weight is the single leading cause of infant death during the first year of life. And it is the leading cause of infant death specifically for African American infants. We also know that Black infants are 2 times as likely to be born premature And we also know that African American infants are up to 4 times as likely to die from complications related to low birth weight. We also know that African American infants are twice as likely to die of sudden infant mortality, sudden infant death. We are failing our infants in this country. And a lot of it has to do with socioeconomic determinants of health, and specifically social determinants of health. We need to do a better job of increasing outcomes and improving those outcomes for infants specifically. In terms of Black women health, maternal health, nationally, 700 women die each year due to pregnancy-related complications. African American mothers are 2 times as likely than Hispanic or Caucasian women to receive late or no prenatal care. We also know that DC specifically has one of the highest maternal mortality rates, and that being 39 women per 100,000 deaths, particularly in the DC area. We also know that African American women as a whole are often 2 times more likely to die related to postpartum and pregnancy-related care. And the more alarming concern here is these rates related to maternal infant mortality and morbidity remain pretty much unchanged since 1985. We have made no progress in improving maternal child health for our infants and mothers of color. And this is something that we need to take a critical look at. As we know, as COVID-19 has hit us, those health disparities are becoming more glaringly obvious now. There is nothing new about health disparities related to people of color. There's also nothing new when we're thinking about how people of color who have pre-existing health conditions such as obesity, as Dr. Wingate mentioned, how we always succumb more severely. We are more sicker as a population as a whole. One common denominator here is socioeconomic status, and we know that. Even when we're thinking about maternal deaths, we know that regardless of the socioeconomic status of a particular pregnant woman, they still have horrible maternal mortality rates in general. But we do know by improving those social determinants of health, we can directly impact outcomes for pregnant and parenting women. Related to Black women mental health, I want to also provide some statistics for that. There was a listening to mothers survey done in California in 2018. And what we found in terms of racial and ethnic disparities also exists with mental health. During pregnancy, 30% of Black women reported anxiety symptoms. We also know that about 20% of Black women during pregnancies reported symptoms of depression. And in the postpartum period, 14% of Black women reported symptoms of anxiety. Most women reporting symptoms of anxiety and depression did not receive any counseling or treatment, especially during pregnancy. I'm going to talk a little bit about how social determinants of health plays a role into that. And so when you think about these statistics, you see where African American women are overrepresented in terms of poor health outcomes, low birth weights, and infant deaths. And so we know that socioeconomic status underlies and is a predictor, increasing morbidity and mortality, and again, is directly and predicts determinants of health. We know that pregnant and parenting women are unemployed or underemployed. This speaks directly to livable wage, lack of insurance, no benefits or lack of benefits for maternity leave, particularly for employment employers. When you think of income-related socioeconomic status, we think about impoverished conditions, stress related to being financially impoverished, stress related to being transient homelessness. And again, we also know that income directly impacts how women's nutrition is met. Nutritional needs during pregnancy is met. We also know that there's a tie-in with socioeconomic status and resources, including family support. And so from a mental health standpoint, we want to make sure we're aware that socioeconomic status has a direct impact on how of anxiety and depression through pathways of stress. We also know that having access to quality healthcare oftentimes is an issue in impoverished neighborhoods, the quality of healthcare and insurance access. And so some of the policy initiatives I want to bring to your attention are the Abundant Birth Project. This is a pilot project that is emerging in California specifically by Mayor London Breed. And she launched this program to try to address infant mortality specifically for African American women. And in this particular pilot program, they are offering monthly incomes to pregnant women in the amount of $1,000. And this pilot project is occurring with 150 Black and Pacific Islander women during the pregnancy period. And this supplemental cash assistance will continue up until 2 years of life for the infant once the baby is born. And so this is considered a first of its kind pilot program, specifically trying to address health outcomes related to socioeconomic stress. And when asked about her views regarding the pilot program, Mayor Breed said she's sick and tired of the deaths in her city. She's sick and tired of the overabundance of deaths related to African American infants. And she was more than willing to champion this pilot program as a means to try something new. As stated before, we've been dealing with these health disparities since 1985. Another area of policy initiative is the Maternal Mortality Review Committee, MMRC. DC has recently established their Maternal Mortality Review Committee, which I do sit as a committee representative. And the goal of that MMRC is to determine the cause associated with maternal mortality, specifically in the District of Columbia. However, these maternal mortality committees are across the country and are emerging across the country to address maternal mortality. We also are trying to track trends in data and/or patterns surrounding maternal mortality. And we're also charged with creating a strategic framework to improve maternal health outcomes for racial and ethnic minorities. In addition, we are to recommend training to improve identification, investigation, and prevention of maternal mortality. And this is a policy initiative that we're hoping that improves outcomes specifically. Another area just to highlight, we need to do more in terms of mental health, in terms of policy initiatives. The Mental Health Parity Act and Addition Act is probably one of the most recent ones, but it doesn't specifically address social determinants related to health outcomes. However, it is supposed to provide equitable access to mental health coverage through insurance companies, and it makes sure insurance companies do not limit mental health benefits for people. So in terms of gaps in policies that we need to address, public health education and awareness specifically related to maternal infant mortality, specifically for women of color. We also need to focus on early access to healthcare, primary care access to healthcare, family planning for improved perinatal outcomes in the African American community. We also need to think about increasing or at least developing mental health urgent care centers. We've made headway with urgent care centers when it comes to physical health, but we may need more mental health urgent care centers, particularly in impoverished neighborhoods and financially stressed areas. Also, training of primary care physicians, emergency room, OBGYN, in mental health and health disparities. A lot more work needs to be done there. And we also need to make sure we're doing routine evaluation and screenings for mental health for everyone, particularly African Americans that we know they're in highly stressed communities and are also stressed from a socioeconomic status. And we must do something to reduce the overall cost of healthcare, because we do know that access and quality is key. And when people do not have the resources that they need to have that access, that is an issue. And the ACA has expanded some of that healthcare insurance access for the most vulnerable in terms of socioeconomic disadvantaged people, but a lot more still needs to be done. And I will stop here so that my other panelists can also chime in on this very important topic.
Thank you, Dr. Cross. And you presented some really alarming statistics, but some great model programs. And so what's really disheartening is that a lot of the statistics that you shared, this is preventable stuff. Like, yeah. We'll now hear from Ms. Weir.
Good afternoon, everyone. Well, I guess it's still morning, just a few minutes till afternoon. And when I thought about what I wanted to highlight during this session, I really thought about, I see everything through my nursing lens because I've been a nurse for over 30 years. And I've been a clinical practicing nurse more years than I've been a nurse educator. But even when someone asks me, what do I do now? What is my profession? The first thing that comes out of my mouth is nurse. And then I qualify by saying, well, I'm a nurse educator. But I guess that leads me to, it's because we see the world through the same set of lenses. So everything I do, I really do through my nursing set of lenses, just like my colleagues, right? On social work, I suspect things that she approaches from that narrative that is ingrained in her, as well as my pharmacy colleagues as well. So with that being said, I thought what I would focus on a little bit here, let me just share a screen just to remind me of where I'm at, is, okay. All right, it's just, well, maybe I won't stay in this view for long because I cannot see my notes in this view on this very old computer, but it's okay. Just the fact that we all have a role to play, basically, and looking at this intersection of the social determinants of health and interventions that we can all do. And what I thought I would look at is those interventions on a micro, meso, and macro level, and just talk about some practical things that we all can do to have an effect, a positive effect anyway. And from that, I'll just look to our notable laureate, James Baldwin, who said, "We are the generation that must throw everything into the endeavor to remake America into what we say we want it to be. And without this endeavor, we will perish." And I find that even though this quote is almost over 60 years old, 60 years old, it's still so relevant. It's so relevant while we're in a time where we're facing a pandemic, racial justice challenges that some of us have never seen or heard before, and an impending, the fallout from an impending election. It's forcing us to throw everything into this endeavor to reframe and remake America. It's forcing us to face our ills. And that may not be such a bad thing. I find it to be a very exciting and hopeful time to see what it's going to look like when we come out on the other side of this. And again, how each of us within our disciplines can contribute to this reshaping of America. And with that, I just wanted to go to the 10 essential public health services that really emerged from, I guess I should say, the social determinants of health. And I really do believe that all of us in our disciplines, whether you're in a health-focused discipline or not, you actually have a role to play in all of these sectors here. For example, I just choose one in which I know all of us play a role. It's in building and supporting a diverse and skilled workforce. Now, the actual statement, when you look into what the Public Health National Center for Innovation and the de Beaumont Foundation intended, they were really speaking about the public health workforce. But I would say that could be extended, again, to what all of us can do within our disciplines, whether it's business, arts, language, engineering, education, communications, the health complexes, what we can do to help contribute to, as educators anyway, to help contribute to building a more diverse and skilled workforce. And I believe it was my colleague, Dr. Cross, that mentioned how we must improve and support the number of practicing healthcare professionals if we're going to have any impact on some of those statistics that she mentioned, a positive impact anyway on some of those statistics that she mentioned. So that leads to, again, just a recap again of what Dr. Wingate presented, which were the different tenets of the social determinants of health. And what I'll do here is just do a very brief exemplar of how each of these we could all, again, play a role in each of these. And some of these are some personal examples of things that I've either done or been involved in, but I think all of you would be able to identify with. Now, it would seem that it's easy to start with the macro, I guess, the big things. What can we all do? Those big things that we can do to play a role here. But, you know, as I thought about this, I said, well, it would seem like that would be the easiest thing to start with, because we can all play a role in policy. We can all play a role in legislative actions, right? The only problem I saw with that was really exemplified just this past week, or maybe it was the week before, on the night of the vice presidential debate, where I realized we are just not all on the same page, and we don't all share the same truths, as we heard our current vice president basically reduce this issue of systemic racism to a presumption, and that was his exact word, a presumption that his competitors made. And then he went on to talk about as well his beliefs about implicit bias. And he was specifically talking about law enforcement, but I believe his premise spreads through whatever he's, you know, applying it to, that he just really does not believe that it's an issue. And in fact, he said he believed that it was insulting to imply that implicit bias was a problem to those populations. And again, he was, just to clarify, he was referring to law enforcement specifically. Thank goodness our HU alumna, VP candidate Kamala Harris, really, I think, addressed that and negated that. But it gets back to my point of, although some of these things that we can do are very simple and very plausible, it is still very challenging when, again, we don't all come from the same paradigm. So again, I'll just give you just a few examples. Something that I do that does not take a lot of time, but yet I do believe it has an impact, because I'm going to continue to be hopeful, is I have an app on my phone, just a simple app on my phone. It's called 5 Calls. You may have heard of it. The motto is spend 5 minutes and make 5 calls. And you can do this whatever intervals you think would work for you. And basically, if you wanted to electronically just send you updates periodically on what legislative issues Congress is working on and the Senate, it will send you, number one, on a different topic, it will send you a pre-formatted template. So when you make this call to your local to your representative or your senator, it tells you what exactly you can say, or of course you can use your own script. All you have to do is identify who you are and what geographic location you live in. It gives you the number, the contact information for your congressperson and your senator. And I'll just give you an example. 3 of the hot topics that came up this week, which again are related to things that my colleagues here already mentioned. One was the Affordable Care Act, and the fact that we must oppose threats to the Affordable Care Act. The major portion of the social determinants of health that addresses is access to health care, as well as many other things that the Affordable Care Act has afforded us the ability to do. So we must defend it, and we must really oppose threats to it. And the way to do that is to be a voice to these people that we have elected. We've put them there to do this work. So we need to hold them accountable. But the only way we can do that is, one, of course, through the vote, but then follow it up after the vote, speak to them and tell them what we expect. All right. Another topic that came up was urging Congress to pass the coronavirus relief bill. And I suspect most of us think that it is I'll stop, not use any adjectives. It is just interesting, I will say, that our Congress right now is spending time, our Senate is spending time to pack the courts when we are in the middle of a pandemic and people need food. People need basic physiologic things like food and shelter that they will not be able to get if they do not get relief from the government that was put here to help maintain their safety, basically. The social determinants of health tenet that addresses is really economic stability, food security, as my colleague Dr. Wingate brought up food insecurity, and also it touches on health. But the big ones is just economic stability, which will give people the ability to have food security and to have shelter. These are basic physiologic things that we believe every American is entitled to. The third one is a little bit more challenging to discuss, which I won't go into details because it can challenge people's beliefs. The abortion issue, and there is, again, legislation that is on the floor but not being heard about the threats to the current law that is on the books. That's the current law that is on the books. And the only thing I want to say about that and how that relates to, again, these socioeconomic determinants of health is that without laws that provide for safe provision for women to control their bodies, abortion is still going to happen. It will just happen in an unsafe way. And we will start to see those health outcomes on women, compounded onto the maternal child outcomes that Dr. Cross presented us with, okay? So again, those are just a few examples from the macro level of just simple but tangible things that you and I can do to get involved, to get engaged. They will not take you a lifetime or a lot of energy and time to do, but they're plausible that you can do them with the time you have. On a meso level, I thought of just how all of us in our disciplines are so active in our various organizations, whether it's your community organizations. For example, I live in Prince George's County, Maryland. There's a Prince George's County Healthcare Action Coalition. Now, although they are comprised of members of the public health department, they actually want community service members on that committee to advise them. Both community service members who have health as a background, as a discipline, and those who don't. And so we provide that advice and expert feedback that they need in order to enact local legislation and policies that will change and affect health outcomes. For example, I remember one of the big things they worked on in recent years is just the lack of sidewalks in some areas in Prince George's County. And I know if you're primarily in DC, you think, well, who wouldn't have sidewalks in their neighborhood? There are plenty of neighborhoods in these suburban areas. You try to go for a walk or you try to go running, you're going to be walking or running in the street, which puts you at risk and then puts the vehicles that are on the road at risk as well. So again, just being active in your community and organizational settings is something simple that you can do. I know I'm a member of at least 3 nursing organizations. And so just being a member, occasionally attending a meeting and giving my word, or being very active, maybe doing some education within those organizations can definitely help. Again, how do those relate to the social determinants of health, socioeconomic determinants of health? Again, going right back to economic stability, education, and really the built community, the built and physical community as well. We have so much we can offer. I also want to throw in a mention for another policy, I guess, or it's really a framework, but I'm sure you've all heard of it, health and all policies. And this goes back to how, regardless of your discipline, you can be the voice that incorporates health and safety issues in whatever policies you are working on within your discipline. Okay, it's called Health and All Policies, and it is a public health framework, basically. All right, and then I'll just mention how HU has a great legacy of service learning and partnerships in the community and community engagement with our students. When I was listening to Dr. Frederick's public address earlier this morning, you know, he even mentioned how, you know, the pandemic has affected what we used to do for spring break, going to other countries with our students to help them engage in building of those communities and health in those communities, but how innovative the students have been and the faculty that have participated in those initiatives in continuing, even though we look like we're not going to have a spring break, or we're not going to have a spring break for this academic year. But the bottom line is that is service learning. That has been a core of what Howard University has done for years, and it will continue, I am sure. In addition, we as faculty just engaging in various types of transformational learning activities and experiential learning activities, ensuring that our students continue to have those. And we can still do those even in a virtual environment, okay? So you will do that within your discipline as your expertise allows, of course. And then I'm just gonna go down to the micro level, and I'll be wrapping up so we can engage in some more discussion. And just, again, give you some practical examples of things we can do when we are talking about addressing this intra and interpersonal relationships and how we can have an effect in these social determinants of health. Pandemic hit. Of course, you know, with my family, I have a big extended family here in the DMV area. We used to get together very frequently. And of course, that all came to a halt. Well, somebody had a birthday and decided they wanted to do something outside on the yard. And I said, well, if we're going to get together, family, as the only health person in my family, I said, y'all should still all go get tested for COVID. We want to protect our elders, and we want to protect those babies, the vulnerable among us. And so people, you know, came up with every excuse. They didn't know where to go. Half of my family don't have insurance. I don't want to pay. It took me no more than 15 minutes to get online, because I am a healthcare worker and I'm engaged in my healthcare community. I just did a quick search of what was available in this area for testing, for free testing. And I got that information, gave them the days, the times that these areas are open. Before I did it, I even went and got tested myself there, just so I could say, I've done it, here's the experience. Found a drive-through location. They did not have to get out of their car. And I just sent it to a bunch of people in a text. I sent it to my friends, a bunch of my HU colleagues. I sent it to my family. I was so surprised how many people actually went and got tested. I guess I didn't think they would really listen to me. But again, it sounds so minuscule. It sounds so minor, but I'm just thinking about the number of people that were impacted. As you know, the more data we have about this disease, the better we will be from a public health standpoint to address it. But in order to get the data, we have to enforce testing. So that's just, again, one example. If I had to bring up one other tiny example, you know, I have grandkids. I have 2 beautiful grandkids. Talking to their parents who were so worried about whether to send these kids back to school or not this fall. Did I make the decision for them? Well, I sort of did, because I'm the grandma, but that's a different story. I really didn't. What I did do was I did a quick search of the American Academy of Pediatrics website before I spoke with them, and a quick search of the CDC guidelines for schools. And when I spoke with them, I was armed with the data I needed to just share with them things they should consider in making this important decision about whether to send their kids back to school. So again, that's just 2 very minor, very personal examples, but they are examples of how I do believe contribute to this on a micro level, looking at the relationships we have, using my disciplinary knowledge and my experience, and then affecting, hopefully positively, and contributing to health outcomes, okay? So again, health across all policies is what I want you all to consider. And with that, I'm just going to go back here and see if there was anything else I wanted to share that I may have had on a slide. And then we will, hopefully I'm sharing screen. Yeah, that's it. As I believe it was I can't remember, I think it was Dr. Wingate that shared the graph of what portions of the social determinants of health have the biggest impact on health. And this is just really what he showed graphically in words from the Alliance for Strong Families and Communities, which basically says more than half of the outcomes, the health outcomes, really are more so related to socioeconomic factors and physical factors as compared to health factors. And the reason why this is impactful to me and my health care colleagues who may be participating or listening to this is that, you know, we really work in the realm of really health and disease. I would say most of my career has been working in health and disease, but most of healthcare occurs outside of that, right? And I'll use pediatrics as a great example. When you talk about pediatric healthcare, most of it doesn't occur in a hospital because most children, if we looked across the board, are healthy. So most of what I have to do related to pediatric health care has to be in a health promotion environment or health promotion endeavor, right? Promoting vaccines, for example, promoting safety initiatives with kids, like using safety restraints, right? As an example, nutrition, as an example. And how do I get to educating children about nutrition? I get to that through the school teachers, as well as through the families. But the point I'm trying to make is, again, most of how I affect pediatric healthcare does not occur in an illness paradigm, right? Even though I mainly work in a clinical environment where there's a bunch of ill kids, most of that work has to occur before those children become ill. So that's where the impact is. And with that, I will close with this last little quote, again from James Baldwin, is that not everything that is faced can be changed, but nothing can be changed until it is faced. And that's why I was very honored to be a part of this little presentation, because I think this is the steps, we are trying to take as an academic community to address the things that we believe need to be changed. Thank you so much.
Thank you, Ms. Weir. And we certainly know that health starts at the home and in the neighborhood and in the school. And there's so much that we can do right in our own backyard. We're going to open the floor up for questions right now. And we have one comment that the intersection of health outcomes and stress among African Americans is critically important. So how do we begin to address that? And we'll let one of our panel members respond to that question.
Dr. Banks, if you don't mind, I think as Dr. Weir mentioned, we're at the forefront. Howard University is at the forefront for service learning, but also providing service to not just the local community, but internationally as well. And I'm glad you brought that up. And I think it would show in the initiatives that are occurring specifically in Howard University. I mean, that's the example I'm going to provide. I can say that in the School of Social Work, we are aware of social determinants of health. And I'll go a step further and say social workers. When we started hearing the term social determinants of health, social workers were looking around like, okay, what's new? We've been impacting those social determinants, and our health colleagues, such as pharmacy and nurses, they know because we work interdisciplinary, of course. But we're talking about this now like it's a new thing, and it's not. And I say all that to say there are some initiatives that we are actually engaged in at the School of Social Work to try to improve health outcomes related to healthcare and mental health. One is the BWET program, our Behavioral Health and Workforce Training Grant, where we're actually giving students focused training on mental health and substance use disorders, and they're placed in their internships at medically needy areas in DC, specific districts, wards, in the DC area, to help improve outcomes, mental health and physical health outcomes for people who are most socioeconomically vulnerable. The other thing is we have a SAMHSA grant. And so with that grant, we've been doing mental health awareness training. And so we've been delivering that training to our colleagues across campus to build their capacity to be mental health first aid responders. And we're hoping that improves outcomes when it comes to social determinants of health. And then the other thing we've been working on, we have a partnership with some area parishes, churches, I don't know the actual name. I'm originally from Philadelphia, I apologize. But we have students, doctoral students and MSW students that are partnering with churches in the DC area, and we are making calls to their members to check in on them during COVID-19 to make sure that they're getting tested, as Dr. Weir is saying, making sure that they have resources, those social determinants. Do they have access to food, healthcare? Do they need support? Do they need education? And so we're also sending referrals out to the communities for members who are demonstrating a need. And so we're hoping that through these service initiatives, through this research that we're doing and these grants that we're receiving, that we're impacting those social determinants of health. And that's just one example of things that I know we're engaged in right now.
Amazing, amazing work. And we're always applauding our School of Social Work. They're right on the battlefield and very interdisciplinary. Dr. Wingate, did you want to respond to that? I know you run the assessment program in the School of Pharmacy. Do you have any shared thoughts about how we could address the health outcomes that are really stressing African Americans today, particularly in the era of this pandemic?
Sure. So like in general, like one area that can really affect stress actually is in terms of healthcare bills. So actually, the number one cause for bankruptcy in the U.S., even whenever we were going through the Great Recession, it wasn't any type of mortgage loans, it wasn't any type of credit card bills, but in fact, it was some type of healthcare bills. So as I guess like a health economist, you would say like one way in which I think that we could actually help to reduce stress is actually help to reduce the economic burden associated with healthcare. So that would include strengthening programs like Medicaid, for example, which is designed for the low-income population. So there's actually been studies which show that whenever mothers have children which need care, or say a condition like diabetes or asthma, and they need to see a physician within say like the next 2 weeks, then Medicaid children have a particularly hard time in terms of being able to see a physician. So in one study, there was like 66% of those mothers could not attain an appointment for their children. So if we're able to do that, I think that would help to reduce the stress in some ways, but also too, just in terms of whenever you have different types of food insecurity, then that's gonna be stressful to you as a family in terms of being able to try to be able to provide for your family. So if you were to provide some type of incentives for families to be able to obtain the needed foods, that would help. And so in some cases, it's not necessarily the money, but it's some type of transportation issue. So for providing some type of transportation vouchers for people to go to the grocery stores, which they would need to be able to access the correct foods as well to give some help in those cases. So.
Thank you. And it looks like we have another question here. And of course, they're saying thank you so much. It's been an informative session. And they're asking about the maternal health and why there's still disparities among the Black women, even when they are having higher socioeconomic incomes or levels.
That's a very good question. There's a lot of research now looking at racism and oppression, healthcare bias specifically. The Institute of Medicine released a report, I think it was about 2001, talking about unequal treatment. And we know that this occurs. And not only do we know that this happens, it's also been sensationalized in the news, right? We know of some athletes who have really went out and spoke about how they were treated in the hospital. A lot of money, a lot of access to care, but they were not listened to when they said that they were not feeling well in the hospital setting. And then their hospital course took a turn for the worse, but it didn't have to come to that point. And so some of the problem, and we're trying to address this, is bias and racism by healthcare providers not listening, being judgmental. That's one. We also know that there's some areas where we're losing a lot of maternity care. There are a lot of healthcare, labor and delivery units specifically. Sometimes they're not one within a specific a radius of an area. And so then those mothers, they have to go farther, travel further just to get the care that they need. And that speaks to access. So one of the biggest areas we're looking at right now is racism, unequal treatment in terms of care regarding providers. A lot more training and education needs to be done. We use the term bias, which I think is a very soft term. And for some providers, it may be a bias, but in some situations, it's racism, and we need to call it what it is.
I have a comment also on that, Dr. Banks, just to add on. And we know absolutely there have been so many studies specifically done in medicine that really did look at, and again, I appreciate your comment about using that soft word bias, but specifically looking at implicit bias and the outcomes that you see in people of color and vulnerable populations because of that. But what they all concluded is, and what the Institute of Medicine concluded in that publication, is that if we increased the numbers and the presence of people of color serving in these areas, that may be one strategy that would impact this problem that we've all identified. So again, going back to this role that Howard University plays, again, when I heard the president this morning talk about Howard University being the #1 provider of this matriculation of students into med school, African-American students specifically, I think is what he said, in the country. So that is significant. Or when you look at, I think he was talking about the top 5 majors that the incoming freshmen are choosing. I was so excited to see nursing was #4. I was so excited because I know, having worked recently in clinical situations in both adult ERs and in pediatric ERs, we are not present. And I am in a normally when I show up in some of these places, maybe not in the middle of DC where I do my clinical work there, but I was in Texas this summer doing a COVID assignment. I was in a normally there. And that can't continue, because if patients that are coming in look like me, but they're not seeing anyone who looks like me, that contributes to the distrust that we know we've seen in the US healthcare system. And I do believe that it contributes to the narrow view that our colleagues, right, who are not from minority backgrounds continue to have, and the bias that they can continue to carry, and the racism they can continue to carry. And the only way we're going to break through that is if they start to see more people who look like us, and we can do that representation. Thank you.
Yes, and so powerful. And that goes back to increasing workforce demand and the role that we have across all disciplines in really producing practitioners and educators and all types of disciplines of people who look like us, because we know what the statistics are saying. And role modeling and model programs. And just finding that space where people are actually doing some of the things that we're talking about. Where are those people? Finding those programs and finding those people. Sometimes we just don't have the resources or the knowledge to know that these programs, they're actually people out here doing wonderful things, or organizations out there doing wonderful things. We don't have that knowledge. So this platform is so very important. I want to throw out there the issue of value and just our value system. And we kind of heard that in many of the comments that the panels shared about, well, I know Ms. Weir talked about, well, do I even need to get a COVID test? So some of the social determinants of health and how our value system exist in the US, and what can we do to help strengthen a community where we actually value the issues that we need to tackle to really begin to eradicate problems that lead us to health inequity. And that's for any panel member to address.
Well, one of the things that happened this summer was the COVID testing stations that Howard University, I believe it was sponsored by College of Medicine, but it may have been through the hospital, opened in different sectors in Washington, DC for testing. So the fact that we took the testing into those respective communities where those vulnerable people are, as opposed to, I was a volunteer with the district's health corps who did COVID testing as well. And they had COVID sites in a few locations, always close to a metro or close to a bus line, always in highly visible areas of Washington, DC. But what Howard University did was they took that COVID testing into those neighborhoods where those vulnerable people live. So you just decreased one barrier for those people getting that testing done. I don't know what the advertisement was to get people to come in for that testing, but again, that shows a program that is tangible, that really served the community that it needed to serve, and took down some of the barriers for people getting to that site.
I would like to add, I think, and if I get the statistics wrong, let me know, Dr. Wingate. I remember on a prior slide that he showed, he talked about 40% of the health outcomes being related to health behaviors, right? And so when you think from a socioeconomic standpoint, right, sometimes we don't realize how much poverty or finances actually come into play with our value system, right? And you hear this a lot of people who are no longer in poverty situations, or people who have good jobs or decent jobs or a livable wage, but yet they still buy in accordance to that an impoverished mentality. What they can afford, it almost is as if that they are making value-based decisions about their health care, nutrition, based on their budget or perceived budget, or need to, hold on to money, and then that is actually impacting healthcare outcomes. So we need to build capacity, support people, and make it more equitable income when we think about employment options, when we're talking about decent jobs, when we're talking about education, Howard University, as Ms. Weir's pointed out, and supporting African Americans in health provider roles, physicians, nurses, for example, pharmacists, social workers, right? But
occupational therapists,
occupational therapists, yes, and all the other providers that are on. But what I want you to see here is that sometimes we base our values are so high, closely tied to our income, to be quite honest with you. Some of the things that we value or perceive value, sometimes we don't value things that we don't think are accessible to us. And that takes a second burner, or we really do not reach for the quality that we're looking for, because first thing we're going to look at is the price tag or our ability. And so, and we need to be mindful of that, and really strive, regardless of income and budget, for the best quality healthcare, the best outcomes related to that, and perception and trust in terms of values, and the historical legacy of how the healthcare system has treated people of color. And we can go all the way back to Tuskegee, and maybe further if we want to even go there with it. But all those things play into values and beliefs about the healthcare system.
And I think that in many cases, Blacks actually do have the values that would be required in order to be able to obtain good health, but it's just the built environment impedes them from doing so. And so, like, there's like the one study which I looked at that showed that the number of pharmacies and number of other health promoting facilities in an environment were actually associated with lower mortality. And so, just as an example, like, I work with some of our pharmacy residents here in Washington, D.C., and so they work for one of the agencies that provides Medicaid. And so they're working with diabetic patients with low incomes. We know that traditionally, diabetes patients with lower incomes actually have higher mortality rates. They're more likely to have complications. But with these pharmacy residents, knowing that these patients had a hard time being able to access primary care physicians, they actually took time to meet with these patients one-on-one. And so we actually saw a significant reduction in terms of the number of the emergency department visits, the number of hospitalizations which occurred. And actually, even whenever we looked at the cost, before they saw these particular pharmacy residents and afterwards, the cost decreased by, like I said, like $5,000 within a given year. So for some patients, it was like even in the magnitude of tens of thousands of dollars. And so I think that that the Black people actually do want to receive healthcare, but we do have to make it in a situation where they can receive healthcare from people who they trust. So, like, that would be like the social workers, the nurses, the pharmacists who are of color. So we actually do have training programs within the College of Pharmacy to help increase the number of underrepresented minorities entering STEM and healthcare programs. So it behooves us to be able to just even early on, as we're going through school, like, to be able to help have role models available for the people so that they know that they too can become a healthcare provider. When I was growing up in South Carolina, unfortunately, I didn't see any type of Black healthcare provider. So I'm very fortunate, blessed to be in the position I am. But as we have more and more Black role models going into the schools and making themselves visible, I think it will help to inspire the next generation so that we will have more healthcare providers to be able to encourage the next generation of healthcare providers. And so, and then sometimes too, I think, like, whenever we would like to see Blacks exercise more, sometimes the built environment impedes them there. As Dr. Weir was saying, sometimes even staying in Prince George's County like I do, it's hard to be able to find opportunities to exercise because there's no sidewalks to allow you to do that. But in Washington, D.C., you can, and so it would behoove us to make opportunities like that more so available to Blacks. And also too, with mental health, we know that there's the stigma associated with mental health services where sometimes it's kind of taboo to get those services, but we just have to let people know that it's okay if you do need mental health services, like, we can help to make you better. So there's nothing wrong with going out to seek those mental health services as well too. It can actually help improve your health and then also to make you better for your family and loved ones as well.
Mm-hmm. And I would like to add, I'm sorry, I just want to do a quick note that we also think about the values that the health systems have, or the culture healthcare organizations as well. At one point, they were talking about models that would bring back visiting doctors. Doctors used to come to your home to meet with you if you were ill or sick. And if we know there are social determinants, if we know there are health disparities, if we know there's an access issues, there's not an access issue on behalf of the hospitals. Hospitals have the capacity, they have the finances and the revenue streams to get out and do more community outreach and to send providers closer to the areas needed and to specifically meet with families if needed. At one point, they were talking about that model, and I haven't heard much of it since then. But I think Ms. Weir's really talked about that when she mentioned how Howard Hospital was willing to go out to bring their testing site to the community. More of that needs to be done, and that requires a change in values and beliefs of healthcare institutions and organizations as well.
And we noticed that this is a systemic problem, and institutional racism is real. How do we penetrate that? What do we do when it's already predetermined for us in many ways? And your thoughts on that?
I think that definitely goes back to working on that macro level to address the structures, right, is what we're talking about. So to address the policies, the legislative actions, the law and legal institutions, and all of us are going to work within our own disciplines to affect those things, the political systems, and again, the international associations. That's how you get to those systemic issues, by collecting the data, which both of my colleagues presented so much of during this time, disseminating that data, and then implementing the policies within those individual disciplines that are going to change the structures and address the systemic issues that exist. So again, if we just go back to something as simple as the Affordable Care Act, by staying engaged, you know, what happened not the first time, I think it's probably the 17th time, the Senate tried to gut and get rid of the Affordable Care Act. What really changed the last time they tried to do it was that individual citizens were finally armed with the information they needed and how the Affordable Care Act improved their life. And they spoke out, and then we saw it go away. Well, until now, and now it's back on the plate, right? But I think there's multiple ways to address it, but definitely looking at it from a macro standpoint, because it is a systemic problem. You have to look at those systemic institutions in order to address it. And we all have a role in that.
And it's almost like we have to find ways to consolidate power collectively. We can't do it by ourselves. It's but we all have a role and a responsibility. And
I would like to add on a micro, I would talk about on a micro and macro level. I do think that our frontline providers and clinicians, you know, we have to step up. You know, we see it all the time where we need to be the voice for the voiceless, or if we feel as though that a particular patient is being overwhelmed by a healthcare system, or that their needs are not being met, we need to speak up and make sure that we address those racist structures. The other thing is, I would like to see more than these pretty policies listed in these healthcare institutions. You know, it sounds good to talk about health disparities. You know, it's good to have these programs, right? But if we're not seeing where these policies are changing the outcomes, again, since 1985, we've been having this conversation, and it's particularly for maternal child health, those statistics have not been changed. So it's not enough to give this illusion of equitable treatment. It's not enough. We need to actually practice this and show where these policies are actually, evaluate them, see if they're actually meeting the needs of the most vulnerable. Sorry.
And if I think about a place like Memphis, where at the same time it was like the hunger capital of the nation, and at the same time it had the highest number of adults who were obese, they actually said that the root cause of it was poverty. And so like we still know that even in situations where Blacks make the effort and they go forward and they obtain like a good education, and their income still lag behind whites, but it's not nearly to the degree in which their wealth lags behind whites. So there's still like a tenfold difference in terms of the wealth accumulation in between a typical Black household and a white household. And so if you want to talk about something that's systemic, you would have to look at the tax structure. So it's still a situation in this particular country where those who are in the lower income brackets are going to be disproportionately affected by having to pay more taxes than those who are actually more well off. And so if we really want to get to being able to solve so many of these problems, we have to make it a situation where there's a more equitable distribution of wealth, whereby the people who have made the effort to go out and educate themselves, they're in harder working jobs, and they can have some type of means of being able to accumulate wealth to be able to buy the correct foods, to be able to have memberships at gyms, to be able to stay in neighborhoods where it's safe, be able to stay in neighborhoods where they feel they can go out and exercise as well too, and be able to have the means to help support their children to be able to go forward and obtain the education as well too, debt-free perhaps, or at least help to pay for some of that cost.
Thank you, Dr. Wingate, and for bringing up the taxes. I didn't go there, but why is it not equitable, and why are people who are making millions and millions of dollars paying no taxes at all, if we want to go there? But some of it is equitable and some of it is just egregious. I'll stop there.
Well, it's part of the structural system that we're up against, and that's why collectively we have to continue to mobilize. We have to continue to fight, but we have to fight collectively as a unit. And so this is obviously a multi-level problem that's going to require multi-level solutions. And it's nice to hear that there's so many programs out there where people have stepped out into the community, these outreach programs, these well-designed programs with real strong outcomes we're beginning to see. And as we wrap up this very robust discussion, I want to kind of give each one of you an opportunity to kind of capture what you'd like to leave the audience with in playing a role at Howard University and in the community and beginning to address the health inequities and the underlying problems of social determinants of health. I'll start with Dr. Wingate.
Okay, so thank you. So I'm actually like a first generation college student, as I mentioned before. When I was growing up in South Carolina, I really didn't see any type of minority healthcare providers in that area and locality. So I think, just as we've been mentioning, like here at Howard University, we're leading the way. So for us just to be visible in terms of being able to go out and role model successful Black healthcare professionals, and so that will help to inspire the next generation. And also too, like just going out and making a difference in our minority communities. We all know that no one will care about the minority communities to the same extent that we will. So I just encourage us to continue to go out and educate the health professionals in our classroom to go out and make a great difference, and also to just go out in the community ourselves and serve as role models.
Thank you. And Ms. Weir?
I was just writing down what Dr. Wingate was saying. He said, be visible, be a role model, and go out and educate. And again, I guess because I only see through my little nursing lens, it's all I do and everything I do, whether I'm in my academic role, really trying to get the nurses who I educate to understand what they're about to walk into and the duty that they have when they walk out, once they get established and become nurses. It's not just a job, like all of your professions, but there's a duty that comes with it. There's a duty with leaving Howard University with a Howard University degree and the legacy it carries with it to serve our communities, to be visible and to be the voice for the voiceless and the vulnerable. Being a role model, again, that's a lot of pressure to have on, but I think that's, you know, what we signed up for as educators, is to be a role model of the best that our disciplines have and bring, as well as the role model when we're in our disciplinary roles. All of us serve them, right? I'm sure social workers still do social work and don't just teach in social work, and the people in pharmacy who teach are still pharmacists, et cetera, et cetera, et cetera. So again, being that role model for what the professionals could look like and what duty we have to serve our communities. And then Dr. Wingate said to educate, and I believe that's across all spectrums, whether it's educating our students, just so they can transition into practice, whether it's forums like this that we serve in to educate each other and support each other, because this has been very supportive to me, this session here, and I hope to others as well, or whether it's educating the community. So again, when I'm in that clinical role, doing a shift in the ER, I am in that role. So many times it comes out that I work at Howard University and how that permeates through what I do, and then educating my patients, educating the colleagues in those clinical settings, as well as just educating even my family members.
Thank you. Yes, very much. And self-care is so important. And so we certainly want to stress that. Thank you, Ms. Weir. And Dr. Cross, you can bring us home here.
I would like to see more providers of color. This was mentioned in the healthcare system. My goal is particularly to see more social workers, medical social workers in the healthcare. I think we play a key role in addressing these social determinants. And having similar models such as this panel here. This is a complex issue, and it's going to take an interdisciplinary approach to tackle it. So we have the wisdom and knowledge of pharmacy, nursing, OT, PT, respiratory therapists, providers, you name the gamut. And so we all have to have a voice here and bring our education and training and our skills to bear to address this issue of social determinants of health and improve economic outcomes for people of color.
Thank you. Thank you, each and every one of you. It's been a great panel, and I'm sure that our audience appreciated the information that was shared today. We are going to wrap up this session and thank everyone for coming. Have a good afternoon.
Thank you. Have a good day. Thank you.
Nice working with you.
Thank you.